Over the years, I've gained so much from so many, some amazing people in my life who have cared with boundless love. Eternally grateful I am to them. I'm also thankful to the teachers who have given without holding back. So, can I give something back? I certainly hope so. Hopefully, this will be helpful to some young physicians in their clinical journey and in their exam preparations. That for me would be amazing. Hi there, welcome everyone to today's presentation by a physician's cup of coffee. This is on clinical approach to Urinary Osmolar GAP, part 10 of the ABG masterclass series. So you are a busy medical registrar who's received a call from the emergency department of a patient who they think has got non-NAGMA metabolic acidosis and severe hypokalemia. They want you to have a look and probably take this patient under the medical team's care. So you are busy and short of time, looking at your watch, so many things to do. Anyway, you've got the ABG results on your way to the emergency department using the formulaic process that we've discussed in the previous presentation. You worked out this patient has indeed got a metabolic acidosis, which is NAGMA. You're not sure of the cause, but you do notice that the patient's got severe hypokalemia. So now with the idea that you have from our presentations, you've got a reasonable idea of what you're going to do and quickly sort out this patient and then get on to your other jobs. So my advice to you is use this process step by step and you will be able to reach a reasonable differential diagnosis. So what is the urinary osmolar gap? Why do we need another diagnostic test when we already have the urinary anion gap, and how do we actually measure the urine osmolar gap? Those would be the issues, and the clinical utility of the osmolar gap, if any, is what we would be discussing today. So let's begin with what is an osmolar gap. Essentially, it's the difference between the osmometer measured osmolarity and your calculated osmolarity using a formula. Any molecule that contributes to the osmolarity would be picked up by the osmometer, and then a measured osmolarity would be given as a reading by the meter. We then would calculate osmolarity using a formula and then deduct that from the measured osmolarity. That would give us the osmolar gap. So this would be the formula that is used to calculate the urine osmolarity. So it's 2 into sodium plus potassium plus urea plus glucose. This would be the calculated urine osmolarity, and this would be deducted from the measured osmolarity given by the osmometer by the freezing point method. Just like the formulas for the serum and urine anion gap are different, the formulas for the urine osmolar gap and the serum osmolar gap are different as well. Both the urine anion gap and the urine osmolar gap are estimates of urinary ammonium excretion when the body has a metabolic acidemia. So we do already have a method called urinary anion gap to measure this ammonium excretion. Then why do we need an osmolar gap to do the same thing? Is there a difference, and is there a benefit to doing the osmolar gap? The answer is yes to both, which we would discuss in the coming slides. This is a slide to emphasize the difference between the urinary osmolar gap and the urinary anion gap, and why the urinary osmolar gap is superior to the urinary anion gap in terms of assessing urinary ammonium excretion. Urinary ammonium can be excreted either as in combination with chloride or ammonium in combination with other anions. When ammonium is excreted with other anions, the urinary anion gap would not be able to pick that up. Thus, you would have a falsely normal result, as in a falsely high urinary anion gap even though ammonia is being excreted, because it's excreted in forms other than chloride. Whereas the urinary osmolar gap would pick up the urinary ammonium excretion in any of its combination. That is what this slide tries to emphasize. So the urinary anion gap and the urinary osmolar gap both are measures of urinary ammonium excretion. However, as mentioned and discussed previously, the urinary anion gap reflects only ammonium chloride alone. But the osmolar gap would pick up any form of ammonia that is excreted in the urine. Those forms could be in NAGMA related pathology, any of the below mentioned combinations. Thus, the urinary osmolar gap is superior to urinary anion gap in picking up urinary ammonium in its totality. So, to re-emphasize, the urinary osmolar gap is a better representation of the ammonium excreted in any of the combination breakdown products, in whatever the etiology of that may be. The measured osmolarity by osmometer would pick up any molecule or any metabolic product that contributes to the urine osmolarity. Thus, the difference between the measured and the calculated osmolarity gives us a better idea of the ammonium excretion, and thus the osmolar gap is a better marker of ammonium and thereby acid excretion. Toluene intoxication is quite important in terms of a general medicinal registrar. He would be many times called to see patients with intoxication, and toluene is quite commonly available as an intoxicant. It also presents as hypokalemia, and hypokalemia gets referred to the general medicine registrar rather than anyone else. So, toluene intoxication generates hippuric acid and benzoic acid with metabolism, and them being acids, you develop a NAGMA. Why NAGMA? Hippurate and benzoic being anions, they lead to reciprocal loss of the measured bicarbonate, thereby the gap between the cations and the anions increases and you have a NAGMA. At this stage, kidneys normally functioning would rapidly excrete hippurate and the benzoic acid very rapidly gets cleared, and now the NAGMA gets converted to a NAGMA, and at this stage ammoniagenesis has not yet kicked in, it takes time. So the acids are excreted with sodium and potassium, and this also leads to a hypokalemia. As time goes by, you have ammoniagenesis setting in, and then ammonia is excreted with the hippurate and benzoic acid, and then this ammonium comes into the urine in a form that is not chloride. So ammonium is not combined with chloride, and the urinary anion gap is unable to pick up this ammonium that is associated with other anions. So you have a urinary anion gap which is falsely elevated even though ammonium is being excreted. It is because of this reason that the urinary osmolar gap would become very useful in toluene intoxication. Loss of sodium creates volume contracted states, activating the RAS with secondary hyperaldosteronism and thereby hypokalemia. This hypokalemia further exacerbates the ammoniagenesis, and this ammonia that comes into the urine mops up all the hydrogens that are available to form ammonium. Thus, the urine pH will rise above 5.5. Later on we would be seeing the difference between toluene and various other RTAs, and this hypokalemia and the urine pH would come up then. Please remember this particular points as to why hypokalemia and high raised urine pH are features of toluene intoxication. Another reason why toluene gets referred to the general medical registrar or the general medical team is because toluene very much mimics RTA type 1. Previously, they even thought that toluene is a subclassification under RTA type 1, which it is not. Totally different pathogenesis, both of them are. So with toluene intoxicity and with RTA type 1, you would have a NAGMA, you have hypokalemia, and the urinary anion gap is raised, and the urine pH is more than 5.5, all of which we've discussed previously. So it very much mimics RTA type 1. So then how do we differentiate these two? This actually I do have a separate slide down the line, but let me go through it briefly. By doing a urine osmolar gap and urine ammonium levels being checked is what would help differentiate these two. What the difference are, I've actually explained in the next two sentences. So why does toluene has a raised urinary osmolar gap? That's pretty easy, right? Because you have a higher urinary ammonium level, your ammonium being excreted, you have a higher urinary ammonium level, thus a higher urinary osmolar gap. Whereas in RTA type 1, there is a defect in ammonium excretion, so the osmolar gap would not be high, and the urinary ammonium levels when tested have to be low, because that's the primary defect in RTA type 1. So though they mimic each other in many features, you can differentiate them by doing a urinary osmolar gap and checking the urinary ammonium level. We have discussed in previous slide in detail as to why we need the urinary osmolar gap, and the normal range is between 10 and 100, and we do take 150 as the cutoff mark for interpretation purposes. We would look at that in a moment. Now comes the question, when to check the osmolar gap. We know why an urinary osmolar gap is needed. The next question is, when would you use the osmolar gap, or what is its clinical utility? So we do know that the urinary osmolar gap is superior to the urinary anion gap in terms of picking up ammonium excretion in its entirety. And the normal gap is 10 to 100, but for interpretation purposes 150 is taken as the cutoff point. Yes, the urinary osmolar gap is superior to the urinary anion gap, but what is the clinical use of this? Why do we need it? Is it helpful clinically? For me, in terms of the NAGMA pathologies, we already have a serum anion gap and a serum osmolar gap. If you suspect, in appropriate clinical situations, if you suspect toxic alcohol or any other toxic metabolite ingestion. Thus, in NAGMA related intoxication or physiology that has become pathological in NAGMA related situation, like the diabetic alcoholic or starvation ketosis or uremic ketosis, we wouldn't really need a urinary anion gap to make that diagnosis. You already have a serum anion gap and a serum osmolar gap, which are very useful. So, what is the clinical use of the urinary osmolar gap? For me, among the NAGMA pathologies, toluene is one situation where the urinary osmolar gap would be useful. In toluene, due to the rapid excretion of the hippuric and the benzoic acid, the AGMA becomes NAGMA, and the time window that you have to identify a raised osmolar gap in the serum is very short. However, those metabolites, that is hippuric acid and benzoic acid, are present in the urine, thus raising the urinary osmolar gap. You would also have a situation where the urinary anion gap would be inappropriately high in toluene intoxication. Thus, the urinary osmolar gap might be or is beneficial in toluene intoxication. That's one. However, for me, the most important situation where the urinary osmolar gap comes in handy is to differentiate the causes of NAGMA. How so? Let's look at it. Before beginning to discuss the clinical utility of a urinary osmolar gap, I would like to point out that this is a slide taken from an article provided by the RACP for educational purposes. And there is a green color asterisk that I have marked, and the differentials mentioned under them would be the ones when you need to keep in mind when you have a urinary osmolar gap that's more than 150. It could be even as close as 400. Let's begin discussing the clinical utility of a urinary osmolar gap. When a urinary anion gap is raised, it could be an unmeasured anion, which is a byproduct of a toxic alcohol ingestion, that is causing the raised urinary anion gap, rather than a renal tubular acidosis. If one makes this statement, is that a legitimate question? Answer to that is yes. Physiologically and theoretically, it's a valid question. But my response to that would be, in a toxic alcohol ingestion situation, the serum anion gap would be a AGMA, whereas in a RTA we would be dealing with a serum NAGMA. If you identify a AGMA and the cause is unclear, then apart from doing the Winter's formula and the delta-delta ratio, we would proceed to do a serum osmolar gap. We already have a test called serum osmolar gap, which should lead us in the proper direction. Depending on a urinary osmolar gap for a AGMA pathology is just doubling up the diagnostic work, is what I feel. So that's not something that I would be too keen on when a toxic ingestion is suspected, and I really don't think you need a urinary osmolar gap to diagnose a toxic ingestion. Apart from, of course, in a toluene intoxication situation where a urinary osmolar gap would be useful. Why so? I'll come to that when we discuss the differentials. Just for completion, when you have a toxic alcohol ingestion situation, the urinary anion gap would be raised, and so would be the urinary osmolar gap. That would be the urinary anion gap and the urinary osmolar gap if we do test for a toxic alcohol situation. It's the same for toluene toxicity as well, because the hippuric acid and the benzoic acid are excreted in the urine. They would be picked up by the urinary osmolar measurement, and you would have a raised urinary osmolar gap. Why would be the urinary anion gap raised in toluene intoxication? Because ammonia carries the hippuric acid and the benzoic acid rather than chloride, and those anions replace the chloride in the urine. Thereby the urinary anion gap would be inappropriately raised even though ammonia is being excreted. Now coming to the most important clinical utility of the urinary osmolar gap, in my opinion, is to differentiate the causes of NAGMA. The differentials of NAGMA can be worked out by using the urinary osmolar gap. We do have identified a metabolic acidosis, we calculate the anion gap. If it's a NAGMA, the pathway is different. We do a Winters formula, we do delta-delta ratio. Then if you are still unclear of your etiology, cause of the NAGMA, you can go on to check for the osmotically active substance by doing a serum osmolar gap. So the pathway for NAGMA is different. What about if it is a NAGMA? So if it's a NAGMA that you have identified in an ABG, then you could work out by doing a urinary anion gap. That urinary anion gap, by being either positive or negative, would be able to differentiate between the RTA causes and non-RTA causes. The non-RTA causes having a negative urinary anion gap. This has been discussed in previous presentations. Now the history and your urinary anion gap would help to differentiate between RTA and non-RTA causes. We have now worked out that, let's say we have worked out that it is RTA that we suspect from our history and from our urinary anion gap. So we could further differentiate the RTA type 1, type 4 from the type 2 RTA by doing a urinary osmolar gap. So as shown in this diagram, if the urinary osmolar gap is less than 150, it would be either type 1 or type 4 RTA. Why would the osmolar gap be on the lower side in type 1 and type 4 RTA? Obviously because they are not secreting ammonium. That's their primary defect. So your osmolar gap would be low. So if your osmolar gap is on the higher side, then the differentials are either a non-RTA cause such as diarrhea, proximal type 2 RTA, or toluene intoxication. Diarrhea and toluene intoxication have ammonia being excreted, and the urinary osmolar gap picks it up, and thus you have a widened urinary osmolar gap. Why does type 2 proximal RTA have a widened osmolar gap? Because the type 2 proximal RTA is a defect in the PCT not being able to absorb the osmotically active products. So you have all those in the urine, and then you have the measured osmotic reading which picks them up, and then you have a widened osmolar gap. And all these pathologies could be further differentiated. For example, type 1 or type 4 RTA can be differentiated by checking for the serum potassium levels, and the type 2 RTA can be worked out by doing a fractional excretion of bicarbonate as well. I actually plan, that is a coming up slide which I would discuss all these differentials in a tabular form. However, there is a planned presentation on the NAGMA and the RTA differentiation to be discussed in detail. I hope to do it in one of the coming days. In this slide, I have attempted to identify specific urinary findings for each NAGMA differential and the differentiating features between them. Why urine for NAGMA? Now we've done an ABG, we identified a NAGMA, then the next step is a urinary anion gap is the next step. So if you have a NAGMA differential, the way to work out and analyze is the urine analysis is what would help us. So various urine features are important to know. Urinary anion gap would help us to differentiate between RTA and non-RTA etiologies, and then the osmolar gap and the pH would help to differentiate between various types of RTAs and their differentials. Related to the RTA, I plan to do a separate presentation in detail, but here I would still discuss them, but a bit briefly. Let's see how we go. let me begin with the 6th horizontal line. That's the urinary ammonium level. That's the primary pathology or defect, right? So in RTA type 1, 2 and 4, the ammonium level is low, and that's easy to understand because the primary pathology is defective ammonia genesis or inability to clear the ammonium level, or acidemia, inability to clear the acid, thereby creating a acidemia in the system. So they have a low ammonia level in the urine. And diarrhea and toluene both are acidemic conditions, so normally functioning kidneys would efficiently excrete the acid as ammonium chloride, and thus you would have high urinary ammonium level if measured. And also to be noted is, if the lab does the urinary ammonium level, then the surrogate markers of urinary osmolar gap and urinary anion gap would not be needed. However, not all labs are able to do or willing to do the urinary ammonium level on a consistent basis. So until such a day, we would require the surrogate markers, urinary osmolar gap and urinary anion gap. And coming to the line above that, the urinary osmolar gap, looking at RTA type 1 and type 4, it is easy to understand that the urinary osmolar gap is low because the ammonia is not being excreted in the urine, thereby the measured osmolar measurement does not pick up any additional osmotically contributing factor. Thus, there is no difference between measured and the calculated osmolar levels. Thus, the gap would be less or less than 150. So, no osmotically active products being picked up by the measurement. Thus, no widening gap. Again, why does diarrhea and toluene have a high urinary osmolar gap? That's also easy to understand because they are kidneys are efficiently excreting the osmotically active ammonium chloride, which is being picked up by the measurement. Thus, the calculated formula doesn't use ammonia, so you have a widened gap in both those conditions. So why does RTA type 2 have a widened urinary osmolar gap? That is because the primary defect in RTA type 2 is a PCA defect of inability to reabsorb the glomerulally filtered bicarbonate. Therefore, you have a osmotically contributing factor bicarbonate in the urine, which is picked up by the measurement and not used in the calculation. Thus, you have a widened urinary osmolar gap in RTA type 2. Now, coming to the line above that, the urinary anion gap in RTA type 1, 2 and 4, it is pretty straightforward as to why they have a positive urinary anion gap, because their defect is inability to generate and secrete ammonia. That is the defect there. Then hence you don't have ammonium in the urine, so you have a urinary anion gap that is positive. That is, the urinary anion gap would be widened because there is no ammonium chloride there, so you would have a urinary anion gap that's positive. As to why diarrhea has a negative urinary anion gap, because the gut pathology diarrhea you have because you have lost bicarbonate in the stools, you have an acidemia there, and the kidneys normally functioning appropriately excrete ammonium chloride. Sodium and potassium will be conserved because they are lost in the stool. Thus, in the urine, you have high amounts of chloride, which has come as ammonium chloride, and then you have less amount of sodium and potassium. Thus, the gap between the anions and cations, the gap between the cations and the anions is significantly reduced. In fact, its gut pathologists have a negative urinary anion gap. So why does toluene have a positive urinary anion gap? That too is an acidemia where the kidneys are functioning appropriately and excreting ammonium. So just like diarrhea, it should have a negative urinary anion gap. Here the difference is that the ammonium is being excreted renally, and it is being done as combined with hippurate and benzoate, both of which are anions. So those anions replace chloride in the urine, thus the gap between the cations and the anions widen, so you have a widened urinary anion gap in toluene intoxication. The line above that is fractional excretion of bicarbonate. It's pretty straightforward if we understand the concept. So the fraction of excreted bicarbonate or any molecule for that matter, what that means is you have a factor that's glomerulally filtered and being absorbed in the proximal convoluted tubule. Now if the PCT is defective, you have that particular molecule being wasted in the urine. So a fractional excreted bicarbonate is the percentage of bicarbonate that is being wasted in the urine because the PCT is not effectively reabsorbing it. So in RTA type 2, the defect is PCT reabsorption. Thus a large amount of bicarb is lost in the urine. The fraction is 15. None of the other pathologies have that defect, hence fraction of excreted bicarbonate would be within normal range for them. Now coming to the top line, that is the urinary pH. Points to remember, normal pH actually tries and reflects or mirrors the urine pH mirrors the blood pH. However, there is a range, and however, for interpretative purposes and diagnostic purposes, 5.5 to 5.3 to 5.5 is taken off a cutoff. Many authors use 5.3, some authors use 5.5, so either one's fine, but just to remember that the normal range is different. Now coming to RTA type 1, which has a alkalemic urinary pH. How come? Because it's a defect in, it's an acidemic situation. You should have acid being you should have an acidic pH, the urinary pH trying to excrete the acid. No, because defect is the tubule's inability to excrete acid, thus no hydrogen ions are being excreted in the urine, thus you have a urine pH on the alkaline side. Now diarrhea and toluene are acidemias, and the kidney should be excreting acid, and which the kidney does, normally function kidney does. Then you should have an acidic urinary pH, acid being there. Then but why do you have an alkaline pH, urinary pH there? The reason for that is the kidneys are vigorously and briskly doing their job, excreting the acid as ammonia. So significant amount of ammoniogenesis, which actually the ammonia comes into the urine and mops up all the free floating hydrogen ions and forms ammonium. Thus hydrogen ions are used up and the urinary pH goes up to a alkaline cutoff level. So the brisk ammoniogenesis by a well-functioning kidney is the cause for a urinary pH being on the alkaline side for diarrhea and toluene. Now moving on to RTA type 4. Now you have a defect in the principal cells. Defect in principal cells ability to secrete hydrogen ions. So you should actually have a alkaline pH, whereas hydrogen ions are not being secreted by the principal cells. So you should have an alkaline pointing pH, but whereas you have a pH that's on the acidic side. So why is this happening? Here there are two reasons. One, to remember, yes, there is a defect in the principal cells, but we do need to remember that the alpha intercalated cells, which are the primary site of hydrogen ion secretion, function alright. So they would be secreting hydrogen ions, keeping the urinary pH down. Also remember that RTA type 4 is a hyperkalemic RTA. Here the hyperkalemia suppresses or inhibits the ammoniogenesis. So you have a low level of ammonia coming into the urine, not able to use up the free floating hydrogen ions. Thus the hydrogen ions contribute to the urine pH being on the acidic side. That's for RTA type 4. Now, why does RTA type 2 have a acidic side of the pH? Here you have a PCT that's not able to actually reclaim the bicarbonate. So bicarbonate is being washed out in the urine, which should be making the urine towards the alkaline side. So the urine pH should be above 5.5 or 5.3. But here you have an acidic looking pH. How is that? Here again there are two explanations for that. So once the body has lost a significant amount of bicarbonate because the because the PCT is malfunctioning, the body has lost bicarbonate, then as a protective mechanism, glomerulus stops filtering significant amount of bicarbonate. Thereby less amount of bicarbonate is washed out in the urine, so that helps to bring down the urinary pH. That's a protective mechanism. And also remember, it's only the PCT that's malfunctioning. Our primary acid secreting site, the alpha intercalated cells and also the principal cells would be able to secrete hydrogen ions, thus keeping the urinary pH on the acidic side. That's the explanation for urine being on the acidic side for RTA type 2. Now coming to the final list of features in this particular slide, that's actually serum potassium. Here I have included serum potassium because that's an important feature. In fact, trying to explain some of the urinary features, we did have to invoke the potassium into them. But in general, hypokalemia or hyperkalemia is actually a significant mortality and morbidity inducing feature. We should know about that. And the general medicine registrar gets referred if for any potassium or any electrolyte, for that matter, any electrolyte related referral would be coming to the general medical registrar. Now let's go to the hyperkalemia, because only RTA4 has a hyperkalemia. That's easy to understand. That's a principal cell defect. So principal cell is unable to secrete the potassium into the urine. Thus the body ends up having hyperkalemia. Diarrhea having a hypokalemia is not difficult to understand, because you've lost so much of the potassium in the stools, and body attempts to conserve the potassium. Essentially, urine will have low potassium as well, but it is the diarrhea that's taken away all the potassium, so you have hypokalemia. Excessive ammonogenesis also promotes hypokalemia, but that I've discussed in detail in the previous NAGMA presentations. I probably would do when I do renal physiology presentations as well. Toluene has a hypokalemia because you have lost the initial ammonia removal or initial acid removal, that is hippuric acid and benzoic acid, initially are taken away with sodium and potassium. Thus significant potassium is lost in the urine, leading on to hypokalemia. Also, because sodium also is lost in the urine, you have a secondary RAS activation, which leads to hyperaldosteronism, which actually again tries to conserve sodium, thereby excreting potassium and hydrogen ions, thereby leading to hypokalemia as well. In my previous slides on toluene toxicity, I have explained the mechanism of hypokalemia contributed by ammonogenesis as well. I actually plan to discuss this in a separate presentation, but however, let me briefly say, why does RTA type 1 have actually hypokalemia? Because RTA type 1 is a defect of alpha intercalated cells. Either there are two pumps on the luminal side, that's the proton pump, that's the hydrogen ATPase pump, and the hydrogen potassium antiport ATPase pump as well. So essentially they try to excrete hydrogen ions into the urine and reabsorb the potassium ions. Because there's a defect in the alpha intercalated cells functioning, the pumps are not able to do this, so you are not able to reabsorb the potassium being wasted in the urine, so you have hypokalemia in RTA type 1. I would explain this with diagrams later on in another presentation. Now, RTA type 2, why does that have hypokalemia? The easiest explanation is proximal convoluted tubule is unable to actually reabsorb the potassium, thus being wasted in the urine, leading to hypokalemia. But that's a little more complex explanation. So you have PCT not reabsorbing the bicarbonate and sodium as well, both of which lead to volume contraction. Thereby you have RAS activation, hyperaldosteronism, sodium reclaiming, and potassium being lost in the urine. That is a major reason for RTA type 2 having hypokalemia. With this, I've explained every rectangle, every feature in this urine profile of NAGMA. Hopefully, it was actually easy to understand. If you have not understood, please let me know. I'll explain. But if you have understood, just draw this, erase everything, and then try to see whether you can actually fill up the blanks. It means you understood the concepts. I've explained the concepts in many slides in a detailed manner, in some of them with previous presentations as well. I would do RTA differentials as a separate presentation another day. This is the principle or the concept of fractional excretion in general, so it's not too difficult to understand. It's pretty straightforward. The amount of the substance that's not reabsorbed in the tubule because of PCT defect, thereby being the percentage that's being lost in the urine. If 100% was glomerulally filtered, the percentage that's not being reabsorbed and being lost in the urine is the fractional excretion. This is again a pretty straightforward slide explaining what is urinary pH is. It's the free hydrogen ions in the urine which contribute to the urinary acidemic level or urinary pH. This particular concept have discussed in detail in the previous presentation, but essentially it's just to explain why acidemic conditions, though they excrete acid in the form of ammonia, still can have a urinary pH that is on the higher side. Okay, you have ammoniogenesis, but urinary pH is still on the higher side. Why is that? This again is a revision slide about the urinary pH. Usually 5.3, some people take 5.5 as a cutoff point for interpreting results. And I've just mentioned the urinary pH in different RTAs. These concepts have been explained in detail in a previous presentation as well, and in this presentation in earlier slides as well. This concept I've actually discussed a few slides before this. I've gone through this many times in detail, but in general, though toluene toxicity resembles RTA type 1, you can differentiate both of them by doing a urinary osmolar gap and measuring the urinary ammonium level. This slide is again this particular concept about toluene and RTA I have discussed previously. Essentially, I have explained in this slide in detail why toluene and RTA type 1 have a urinary anion gap that is high. Both of them have a urinary anion gap that's high, but by totally different mechanisms. Okay, one has a urinary anion gap that is high because the primary defect is acid excretion. The other has a urinary anion gap that is inappropriately high, even though ammonium is being excreted, and the reason and the pathology behind it I have explained in detail. If you have a read of this, you would understand that very clearly. This again is a revision of the concepts that we have discussed multiple times in the past as to why the renal tubular acidosis have a raised urinary anion gap. This is a slide which I had explained very clearly a while ago in this particular presentation, and the concepts and the physiology related to each finding I've explained in detail. Now, if you apply those principles, you should be able to fill in the gaps pretty easily if you understood that. Have it go and see how you do. This is again, a revision. I've done this particular slide and I've explained it in detail earlier on, just to understand or just to revise as to the urinary osmolar gap being a helpful tool in a differential diagnosis of NAGMA pathologies and how to differentiate various RTAs and toluene using the urinary osmolar gap. Just a revision. Have a look, remember what we've discussed earlier and apply them and see whether you can actually understand this particular slide. Alright, this is again just a revision of urinary acid excretion or urinary ammonium excretion in terms of the urinary anion gap. So this is about the NAGMA etiologies between RTA and non-RTA and the urinary anion gap in these pathologies. So in terms of toluene intoxication, is the osmolar gap of any use? So in terms of the serum osmolar gap, because the hippuric acid and the benzoic acid get cleared very rapidly, even the NAGMA gets converted to NAGMA quite earlier on, and we might actually not pick up a serum osmolar gap if we do one, but because the hippurate and benzoate are in the urine, both the urinary anion gap and the urinary osmolar gap would be raised in toluene intoxication. Thus, in toluene alone, the urinary osmolar gap in terms of toxic alcohols or NAGMA pathologies, in toluene alone, the urinary osmolar gap I think would be useful. As I have discussed earlier on, doing urinary osmolar gap to diagnose the other NAGMA pathologies, I don't think it is really needed, because you already have a serum osmolar gap which would identify those osmotically active molecules in the serum. This is just a summary and a revision of what we've discussed about the anion gap and the urinary anion gap and the urinary osmolar gap. Do we need to be doing the urinary anion gaps and osmolar gaps? Don't we have a direct urinary ammonium measuring ability to do that? Certain labs actually do, but many labs don't do it, and many of the labs don't have the facility to do it. So these measurements are still in use. Maybe one of these days the labs might be able to directly measure the ammonium level. Truly grateful to so many in my life who have given so much. Thank you very much. Did you think this particular presentation was useful? If you thought so, then please hit the like button and subscribe. Down the line, I have now discussed the urinary anion gap and the urinary osmolar gaps, serum and urinary osmolar gaps. All these topics have been discussed. I plan to do the renal channelopathies and the approach to renal tubular acidosis. Based on what we've already discussed, I would like to do the renal tubular acidosis and the renal channelopathies, which then followed by, before doing the renal channelopathies and the renal tubular acidosis, ideally I would actually like to do the renal physiology. Let's see how that goes. This breathtakingly beautiful nature's gift is the Crocodile National Park in Australia. Have a look at this amazing gift from nature. It will leave you speechless. Once again, thank you very much for your patience. Let's meet on another day with another topic.